In the room presenting, we have Dr. Stephen Lyndaker, Medical Director of Fort Drum Regional Health Planning Organization and owner at Lowville Medical Associates. We also have Charlie McArthur, Quality Analyst here at FDR HPO, and myself, Joanna Loomis, Director of Provider Strategy and Transformation here at NCI. So thank you so much for joining this HCC Coding 201 presentation. And we'll get started. All right. So I think those of you on the call likely know we as an ACO have worked on HCCs for several years now. So we wanted to really take an opportunity to go a little bit deeper today, hence why this is a 201 presentation. I'm going to start by reinforcing the why behind HCCs, and then Dr. Lyndaker will take you through several case studies to make this real from a patient and coding perspective. So HCCs come into play in value-based payment contracts and Medicare Advantage. And why is this? That's because the amount of shared savings in a Medicare Advantage, the amount of premium payments made to the plan, is dependent on a number of factors. Certainly how well one does with quality, your outcomes, your costs, your utilization, but also the acuity of care of your patient population. In other words, value-based payment sets a benchmark of how much you can spend on your patients, but how do you set that benchmark? And there's no way around that to do it fairly or accurately other than to take into account the specific risk of a specific population. And HCCs is one model that does exactly that. There are several models that can account for risk, but the HCC model is the one that was chosen by CMS for ACO Medicare contracts. And so as we kind of get into this, I'll start by saying HCC stands for hierarchical condition categories, but it is not nearly as important that you know what that acronym stands for than it is you know how they work and what you can do to actually use them and make them work for you. So back to this notion of acuity of care or the risk of your patients. What goes into assessing that and quantifying that? There's several factors. First, there's demographic factors like age and gender. Those are more or less automatically communicated to CMS and they come with their own risk score. But then, of course, you have to take into account each patient's specific medical conditions. And how is that communicated to CMS? It is sourced entirely from diagnosis codes that ride on claims to CMS. Another key point to keep in mind here is that HCCs are used to predict future health costs, specifically in regards to chronic conditions. So HCCs are collected throughout one calendar year to predict costs for the following year. In other words, the predicted cost of our ACO's population right now in 2020 was partially determined by the HCC codes and the diagnosis codes that you submitted on claims in 2019. And sort of the opposite is true to carry that on. Right now, what you are submitting in claims in 2020 will be used to predict the costs of our population for 2021. Obviously, there will always be medical costs that are certainly unpredictable, car accidents, spider bites, etc. But this model does its best to account for significant drivers of costs, which are chronic conditions. So as you can see on this slide, there are about 9,000 chronic disease category related ICD-10 codes, and those are in turn grouped into about 80 HCC categories. And each of those HCCs has varying risk values. The higher the value, the higher the risk. The higher the risk, the more money we could reasonably be expected to have to spend on that patient in the following year. And also keep in mind, as we've noted, diagnoses are communicated via claims, but really think about this as primarily physician office claims. That's both primary care and specialty. There are actually certain claim types that are excluded from HCCs, and that includes things like skilled nursing facilities, hospice, home health, lab, and imaging. So really, your influence as primary care and specialists, it can't be overstated when it comes to HCC. This is really where the magic of HCC happens, is with all of you on the call today. So how do you arrive at a final risk score for a patient? It's, again, because this is a prospective model, each year, each patient's slate is actually wiped clean. CMS does not assume that a patient's chronic conditions remain static over time, so they have to be updated. To a certain degree, that makes sense. Chronic conditions can sometimes come and go. It is possible for people to no longer have a chronic condition, but some things sort of defy logic when it comes to this. So, for instance, if a patient has had a leg amputation, believe it or not, if you do not code for that amputation this year, CMS thinks that that person's leg got reattached magically. So we have to make sure that we continue to code for those blatantly obvious things again and again, year after year. And in the case of an amputation, that actually does carry a significant HCC risk factor. So you definitely want to catch those as well. Each of the demographic factors that we talked about in the last slide has a score, and then every HCC also has a score. So when you add those together, you get the patient's sort of semi-final score. CMS does normalize values around 1.0, but when all is said and done, CMS multiplies a patient's individual final HCC score by a baseline cost unit to yield a final expected cost for that patient. And what does this actually look like in practice? Here is just a sort of hypothetical example, and don't take these dollar figures as set in stone. This is meant to be illustrative. Obviously, these fluctuate, but here you can see the very first factor is this patient's age and gender. So we'll pretend this is a 76-year-old male. If we coded nothing for that person for the entire year, then we would be left with a risk adjustment factor score, or an HCC risk score, of 1.062. And that means that we as an ACO could be expected to spend about $9,600 on this patient in the following year. But you can see what happens when additional diagnoses are added. They significantly increase the score of the patient, and that in turn has a multiplier effect in terms of the expected annual expenditure that we can, in essence, spend on that person for the following year. So this slide, sort of in a nutshell, tries to summarize the why behind HCCs, and I'll actually talk this through from the bottom up. So as an ACO, you want to have the highest appropriate benchmark spend for your patients. You get that by communicating the seriousness and complexity of your patient's risk to CMS. How do you do that? By generating the highest appropriate HCC score for your patients. And in turn, how do you do that? By conducting a thorough and specific coding of all appropriate diagnoses. So if there's two words that I would really want you to resonate with you after this presentation, it's thorough and specific. In other words, what is the scope of this patient's chronic conditions? So maybe diabetes has been the overarching clinical focus for this patient, but I haven't included codes on their morbid obesity, for instance. And as far as specific, what is the depth and severity of this patient's diagnosis? So if this patient has diabetes, do they actually have complications? And if so, is that reflected in my choice of diagnosis codes? I want to illustrate just how impactful it is when you add a new code or adjust the severity of an existing code, or simply ensure that all relevant codes from the previous year are captured again this year. What this graph shows is that we as an ACO increased our HCC scores by a relatively minor amount from 2017 to 2018, as indicated by the two arrows above our two largest Medicare patient categories. That would be our age non-dual and our disabled populations, which together account for about 90% of our ACO population. That little increase actually increased our average per patient annual benchmark by about $600, which, if you have a total of 11,000 patients like we do, equates to an ACO-wide benchmark increase of $6.6 million. Let that sink in for just a moment, because really, if we as an ACO did nothing but focus on HCC coding, then that alone would have a significant effect and impact on our bottom line, on what we could spend as an ACO, and in turn, our chances of getting at shared savings. Obviously, we as an ACO do not just focus on HCCs. HCCs is a little bit of a sort of a back-end office sort of aspect of ACO strategy. And we have several other patient-facing initiatives like transitional care management, patient outreach that are very strategic and critical to our operations. But I share it just to underscore really the significance and the impact that HCC coding really does have in terms of ACOs overall. So finally, who is involved in this process? As with a lot of different processes, it takes several roles to make HCC coding successful. So providers, as the patient-facing members with authority to select diagnosis codes, certainly have a huge role to play. You monitor, evaluate, assess, and treat patients' diagnoses. You include supporting documentation in the EHR, and you select diagnoses from EHR dropdowns. And as we mentioned before, the fact that most HCC action happens from physician office claims through primary care and specialists certainly underscores your importance in this process. But coders and billers are certainly also critical because you are often the gatekeepers of the codes as they are finalized on the claim. You are in a position to catch opportunities to add codes based on what you're seeing in the provider's notes. And on the flip side, it's important that you know the why behind HCCs so that you don't mistakenly remove a diagnosis code because it might not be implicitly or explicitly related to payment of that claim. And finally, administration and leadership definitely have a role to play in this. They definitely need to understand, again, the why behind HCCs. Obviously, our success in doing HCC coding is going to impact our ability to succeed in a value-based arrangement. And so to the extent that is significant to administration and leadership, that should resonate in terms of the ability to support your care teams in conducting HCC coding efforts. So with that, I will actually turn it over to Dr. Lyndaker to illustrate HCCs in action through several patient-level case studies.
All right, thank you, Joanna, very much. So thorough and specific. Those, I think, are aspirational and hopefully attainable. I guess my overwhelming hope here is that we can do that in the context of our daily work, so that we're not doing this as an extra, a one-off, yet another thing that we're trying to do during the course of the day, but rather we can incorporate this as we go through the normal activities of our day and documentation in our charts. So I just want to go through these fairly quickly to just kind of give examples of what it can mean to you know, diagnoses. So here's a type 2 diabetic. You can read has COPD and O2 dependent, has obviously some DME paperwork that's signed. So you kind of have a couple ways of thinking about this. The first is on the left. That's, you know, cut and dry, fairly simple, with a complications or a RAF or HCC. These are kind of, they're interchangeable. They're not really. Charlie knows they're not, but I don't know enough not to know they're not the same thing. So on the left is the simple stuff. On the right is really clinically not telling us anything we don't already know as clinicians, but it's documenting that diabetic with hyperglycemia and the fact that someone in fact does have chronic respiratory failure with hypoxemia. Those two just bump the code significantly and are important that we capture those diagnoses. Next is someone with hypertension and a BMI of 37 is in addition to hyperlipidemia and sleep apnea. Again, we go to the two different examples here, and in this case, the big takeaway here is that their BMI is above 35 and they have at least 2 chronic conditions that are obesity related. So they meet the criteria for morbid obesity and not with a BMI greater than 40, but rather greater than 35. Diabetes, polyneuropathy, toe amputation, you know, a lot of coordination of care, still smoking. You know, these are time-consuming folks, as we all know. Again, getting specific on the diabetes with polyneuropathy. And then the bigger thing is probably here that jumps out is that acquired loss of the great toe. Anyone who's had an amputation, anyone who has an ostomy tube, anyone who has DME-related illnesses, you need to capture that in the medical record. Again, does it make a big difference on how we clinically think about this person and treat them? Probably not, but it certainly does in terms of HCC or a RAF score. Hypertension with a remote colon cancer history and a colostomy with an upper respiratory tract infection. Again, it's getting at the colostomy issue and that they have something extra, something more complicated that adds significantly to their HCC. Now, again, to circle back to what Joanna said is the HCCs were developed in 2004 and really is more an actuarial way of thinking about people. What will their costs be in the future? So again, as clinicians, we're really thinking about the here and now, and we're not necessarily thinking about the future as an actuary would do. So it kind of is a refocusing, but it's still in the context of care. 76-year-old with cellulitis, liver transplant, atrial fibrillation, etc. Again, documenting the specific type of AFib, the fact that their liver transplant patient needs to be included in their diagnosis list. So again, you know, anything that potentially complicates, even if it's for potentially in the future, needs to be documented. Major depression, improving, had a new medication started 6 weeks ago. This gets specifically to the issue of major depression and doing some type of assessment of that in addition to the going from an unspecified to a specified. Not all unspecified diagnoses have zeros, but generally speaking, if at all possible, if you can be specific with any kind of diagnosis, mental health included, there's clearly a benefit in coding it that way in terms of HCC scores. So these are basically some of the common coding or diagnosing errors, missing diagnosis, chronic conditions not being coded. I'm going to add in here, I think, that when we're going over, particularly an annual exam, and we're looking through people's charts, we really need to kind of clean up, I think, the chronic problem list and try to look for the most specific diagnosis in that chronic condition. So if someone had diabetes in 1995 that's uncomplicated, and then in 2005 has diabetic neuropathy or nephropathy, really that needs to be the prominent diagnosis. And what we're doing in our office now, we've done it for about a year and it's been quite helpful, is we're inactivating those old, less specific or lower HCC conditions. They're still visible, but they're not active. We're making sure that we're using the most up-to-date and the most specific diagnosis for these chronic conditions. Also, trying to really clean up the history of conditions and using the more real-time diagnoses if possible. And then the last thing gets to do with that meat piece that Joanna talked about. So that MEAT, coders use that all the time, every day. So what I think often happens, the monitoring and evaluation often gets caught up in the note itself. The assessment and the treatment are the two that sometimes get dropped. And the assessment is if someone has a history of breast cancer, and there's no clinical evidence of breast cancer, but they're still on Herceptin or they're still on some type of hormone modulator. Even if you're not going to bill for that diagnosis specifically, if they're still followed by oncology, for instance, you can still do an assessment that says no clinical evidence of disease, and the treatment is documented in that they're on Herceptin or they're on other hormonal treatment regimens. So that can ride with the claim. It doesn't necessarily have to be used for what your billing will be, but it still can go with the claim and it's legitimate. And it's not history of breast cancer, it's breast cancer. BMI, we talked about. Cancer is again, you have to be clear about this. A lot of questions come up with this. What I tend to say is, listen, if it's something that you're considering, if it's part of the way you think about that person in terms of differential diagnosis or treatment, then really it is valid to use that in your diagnosis and ride with the claim. The other things we've talked about, amputations, organ transplants, indwelling devices, anything that you're prescribing durable medical DME stuff is important. So if someone's in a wheelchair and they're wheelchair bound, that makes a difference. If they have frailty that's significant and requires other devices, those sorts of diagnoses make a significant difference. So strategies and best practices we've kind of talked about. I think annual exam, especially the annual wellness, especially if there's a little additional time to go through and really clean up the chart and the problem list, that's the time to do it. And when you're doing it, I think we'll find that the HCC scores will get higher. Billers and coders can look for gaps. We've included a really nice crosswalk at the end here on the resources that really crosswalk diagnoses to specific HCC categories. So it lists out all the ICD-10s that are valid for vascular disease, for instance. As it turns out, vascular disease is a big deal, and it's also a huge deal in our ACO because we don't code that very well, I don't believe. And I'm certainly guilty of that as well. So there's things that billers and coders can do, and as a quick reference for providers, I think it may be a benefit as well. When an insurance company asks about a suspect condition, when roster notes said, hey, you're missing an HCC, and it kind of plumps in vascular disease, and you're not really sure if that meets the criteria or not, there is a quick reference that we've given that says, okay, vascular disease, these are the 50 ICD-10 codes that meet that criteria. You can just quick reference it and move on. It's a little granular, but I think in the long run, it's a good resource for us. Again, the suspect and the ACO conditions we talked about. And then the functionality, each EHR is a bit different, but I think that certainly the suspect condition and the missing HCCs are important. I think there are some prompts built into some of our EHRs that help us with choosing the most specific and highest level of complexity in our HCC. This is just a roster note. It looks different in everybody's chart, so don't hold me to it, but this is kind of what comes from FDR HBO. And I think it's worth noting that if those HCCs are due, take an extra few seconds to make sure that they're in your notes. Obviously, if they don't, if the person has asthma and they got coded as COPD in the ER, well, so be it, but it's still, it will help us, I think, capture some of these. The other thing is I'm using a little bit more the HCC value. If you have a complicated patient and they're less than 1.5, you need to look at that because something's not gelling. You know, it's just a gestalt, but I tend to be doing that more and saying, this isn't really adding up. Why is that? And often I find out that, in fact, there's things in there that I could be coding that I haven't. These are some of the uncoded HCCs. I mentioned the vascular disease, the COPD. Specified heart arrhythmias, I think that's another one certainly that I could do a better job. This is more just for you to kind of review and digest a little bit. Again, it's not to be perfect, but it's to get some of these bigger HCC scores, to get these really identified. I think rheumatologic conditions are another thing that we as primary care may not be coding, but they're certainly important. Hematologic disorders, I think often there are some things that we are missing, like, you know, really anemia of chronic disease or chronic anemia. Those diagnoses need to at least be in the end result of our note that goes on, that gets batched and posted and sent to CMS. All right, so this one I think goes back, are we switching over? This is me yet, sorry. I can't remember the transition. So again, most of these we touched on. I think, you know, both primary care and specialty care play a role here. I steal specific coding from subspecialists all the time, quite honestly. When I get a consult note and I see that they coded it a little more elegantly than I'm trying to take that extra time to do that. And then remembering that, you know, there are some additive HCCs. I think probably the one that I miss is the person who has long-standing hypertension and an element of diastolic heart failure. That diastolic heart failure hasn't necessarily made it to their problem list. That's a big deal. That needs to get there. And then if it does, and you add CKD, even a CKD3, that increases the HCC as well. So there's a lot of little things like that that go into HCC scores, and you know, I don't profess to be an expert. At the same time, I do think we need to be thinking about those additive, and again, I think up to 12 diagnoses can ride on that claim. And even if we're just billing for 4 and only really treating maybe 6, the other 6 are important potentially to get in the claim. So those complicated people, again, you know, you can really load in the diagnoses that ride with the claim, even if you're not billing for them. All right, so I think I'm going to pass it over to Joanna again. She's going to talk a little bit about the COVID considerations, and then we'll be opening up for Q&A or other thoughts that you may have.
Thank you, Dr. Lyndaker. And just a quick note on the additive HCCs. Some of you on the call probably have heard this before, but it may be something new to some of you. So just for the sake of clarity, what that really means is when particular disease combinations are present, such as what Dr. Lyndaker mentioned, also things like diabetes and CHF, the risk is actually higher than if the scores for those 2 separate diagnoses were simply added together. So it's a classic sort of the sum is, you know, it's the whole is more than the sum of the parts type situation. So we don't expect our partners to be experts on the various additive HCC combinations. That's not what we're going for, but just sort of underscoring that, again, to the extent that you can code diagnoses, again, as specifically and thoroughly as possible, then that's going to give us a much higher chance to sort of achieve as many of those additive combos that we can, which does significantly impact our HCC scores. So kind of touching on current situation and the COVID-19 considerations, CMS ruled that overall ACOs would actually have certain costs excluded from our reconciliation for costs in 2020. So that obviously works towards our advantage. In other words, if a patient has an inpatient event with an associated COVID diagnosis code, then that will actually trigger CMS to remove all costs for care for that patient, beginning with the date of their inpatient admission, and then actually going through the end of the month following their discharge. So again, removing all costs, whether they're COVID related or not, but again, it has to be triggered by an inpatient service when COVID is an associated diagnosis. That's obviously true. It has not a huge bearing on HCCs. We just wanted to make sure partners knew that. We also wanted to really underscore and make sure that it was very clear that even though those related costs will be excluded from the ACO's financial reconciliation, the diagnoses codes that ride on the claims associated with all of those services still count towards HCC scores. So that work still very much counts. And in case anyone were to ask, there is no COVID HCC, although of course CMS in its eternal wisdom may decide to create one. Time will tell. Although again, keep in mind, HCCs are really more about chronic conditions. So we're still learning about COVID every day, and there may be some chronic aspects to that. But as of right now, no COVID related HCC. Another thing to note, COVID related, is the difference between video-based telehealth services and audio-only or telephone telehealth services. At this time, diagnoses that are included on video-based claims are incorporated into HCC scores, but the audio-only or telehealth ones are not. Although, as you can see, there are several advocacy groups that are pushing to include those for HCC risk calculation as well. And finally, want to make sure, we've talked about this to partners when we meet with you sort of one-on-one every other month, but annual wellness visits can be conducted via telehealth. And so to Dr. Lyndaker's point that annual wellness visits are a really great tool and a good strategy to sort of bake in HCC coding awareness into your sort of daily practice, it is significant that if you're not able to get people into the office, which I think right now we're transitioning more out of the telehealth world and sort of resuming normal in-person operations. But again, you can conduct those annual wellness visits via telehealth as long as you are doing that as a service. Then the HCCs that you code for that will ride on the claim. So in closing, just like to emphasize and underscore that HCCs really truly do matter. They have a huge impact on the success of value-based payment contracts. And really moving beyond the ACO, if you're good at HCC coding, you may find that Medicare Advantage plans might be willing to financially incentivize you to code as well. And we have seen that with various Medicare Advantage plans in our region, incentivizing providers for conducting annual wellness visits and thoroughly and specifically coding for diagnoses. They are certainly financially incentivized because that affects the premium payments that they get. Also, arguably, it can really impact your work with really every population. Medicaid, for instance, uses a different risk model, but again, they want to have patients as thoroughly and specifically coded as well, because that would affect, in turn, their premium payments, and it can certainly affect the success of value-based payments in terms of our Medicaid contracts as well. And I would also argue that, you know, even aside from the financial implications, success in HCC coding is good practice for you and your patients because it reinforces, you know, the importance that you all know of thorough review of all of the conditions affecting the patient. So as you walk away from this webinar today, I challenge you to really consider what your role is in terms of HCC coding. What's my team's role? How do those roles sort of intermingle and relate to one another? Does my EHR have tools that can assist with this process? So we very specifically did not really touch on EHR capabilities during this presentation, just because we know our partners all use different EHRs. And even those of you who might use ECW, you may have purchased different modules that may look different among the different practices. And so we really couldn't do justice to all of the different capabilities that your EHRs have. I do know that some EHRs have the ability to sort of poke you with suspect conditions, you know, based on the things that they're seeing that you're putting into the EHR. They might pop up some suggestions for you in terms of diagnoses that you might not otherwise have been thinking about. And some also prompt you to consider diagnoses that you coded last year that you haven't yet coded this year. Again, that's a very similar feature to what we give to you in the form of roster notes. But if there are questions offline, we'd be happy to explore those options with you and your teams. Again, just let us know. I think you all on the calls know how to get to us. You can email myself or Laura Yacht, who I believe all of you are familiar with, and we can work with you on that. And finally, consider what your current workflow is around HCCs and what could be done to enhance this process and really make things move even smoother. So with that, we'll open it up, and I invite any questions that anyone has. I can see right now on the Q&A feature, looks like I'm not seeing anything that's been submitted during the presentation. You can also, I believe you should be able to unmute yourselves if you want to just join in via audio, or if you have any points for discussion.
I'm actually here.
All right.
Can they hear me?
I believe they should.
So one thing I've always been confused about a little bit is the acuity conditions. So for instance, acute MI had a score of 0.22 something. So if I see a patient for a hospital follow-up, see 2 to 3 weeks later after the MRI, so they're going to go on for cath or what have you. high school, but acute MI. And then obviously, unless they have a second event the next year, that dries out.
That flips to coronary artery disease.
Right. But it would help with figuring out payment for next year.
Yes.
And actually, it could adjust the payment for the present year because they now allow, remember the 3% rule. So we can actually, ACOs could not, like Medicare Advantage can raise their HCCs by a certain percentage points. ACOs could not. So we didn't have that option. We now have the option, we can raise it by 3%.
Okay, so at the time of a TCM, let's say.
Yep.
Or any hospital involved with a quite big TCM. For any acute condition, hospitalized pneumonia, for heart failure, for sepsis, you can code, keep on coding, at least that initial visit. You could do the HCC for acute sepsis, or whatever.
Yep.
I mean, I guess the internal cue that I use is, am I doing the meat? Am I, monitoring, evaluating, assessing, and treating in some fashion? And if the answer is yes, that's a valid, even if you say, no evidence of ongoing disease or currently asymptomatic or resolving or, I mean, that's still an evaluative.
No antibiotics, for antibiotics needed.
Yeah, exactly. I mean, I think that's valid. And then how long you do it, I think that just has to pass the clinical sniff test.
We almost got to get in there once.
Exactly.
For that year.
Yeah,
Yep.
good
So,
point.
because I'm sure I'm not singularly alone and not really realizing.
Oh,
Second question, let's just other questions. So, the HCC is used for nursing home patients of the county. That's what you said.
If it rides on the nursing home claim.
Okay, so if I bill for a nursing home visit, my claim counts.
It should, and I don't know, Charlie, if you have any other, I'm looking to you as a,
Yeah, so if you're billing a visit code in your clinic,
Yes.
then
That
absolutely,
counts.
that's what counts.
yes.
Yeah,
Okay.
it's just those sniff codes that we.
Yeah, I got you.
Yeah.
Okay. I think those are the questions I had.
Thank you. Anyone else on right now who has any questions? Again, feel free to just unmute yourself or to ask in the chat box. Let's see. Oh, it looks like we do have a few. Dr. Jason White asked if any other providers have a resource or rule of thumb in finding a code that does not fit. And I don't know, Dr. White, if maybe you can elaborate a little bit more.
The code doesn't fit the patient who has.
or it doesn't fit necessarily. So the last resource, and we added this one late, is a crosswalk. And at least in my mind, it was the best. It was put out by, I think, Anthem Health. And it's based, Charlie thinks it's based on or Empire Health. Yes. So, but Charlie thinks it's probably based on right out of the CMS, and I think it's called, yeah, there it is,
Yeah.
CMS, it's called a crosswalk. So I think that one, to me, if you know kind of where you want it to go in the HCC descriptor, then you can go back and see if the ICD-10 code fits and vice versa. So sometimes, like, roster notes will say disorders of immunity. Well, what the heck is that? Or coagulate or disorders of coagulation or vascular disease, things that clinically don't necessarily jive with the way I think of it, but this at least provides the ICD-10 piece that allows you to crosswalk it back. And honestly, I guarantee you this is out of a computer program. So a computer programmer did this, and then they printed it. So I think there's probably more elegant ways that this could be done within, you know, the back office, the billing office, is my guess that this is one of the add-ons that EMRs sell that could be potentially of benefit. But at least on the kind of quick provider side or biller side, you could at least look at this. So I think this is a pretty good source or resource in my opinion, and hopefully this would help, Jason. I haven't used it this way, but I ran across it recently and I thought, well, this is perfect for our talk today.
And Dr. White said that you answered his question well. Thank you.
Yeah,
I want to
God
add,
bless you.
I want to add one thing to something Steve said. This does come from CMS, and they do review it every year, so it changes every year. So if you have this hanging around,
Get rid of them.
you gotta update them every year, because they use different versions, and they use hybrid versions. So right now, we're using version 12 and version 23 as a hybrid.
Oh, jeez.
Yeah, it's complicated, but
So we should, does this have a date on it? I know this is recent because I literally looked this up.
17.
17, is that the most recent?
No, this
No.
says included in 2018 CMS.
See version 22 model.
Yep.
So, it's not, we have to find it, but I can certainly do that.
So we may have something even that should be, yeah, so that would be important to get out to our partners, I
Yeah.
think. Yeah, because
I'll look into that. But it's always, something that Jeff and I look at every year. And then I get the appropriate, I probably already have it on my computer because I download it every year.
all right.
All right. One last call for questions, and I did publish in the Q&A, but just sort of to let everyone know, we will email everyone in attendance this week with this presentation, which does include the links to references. We will locate an even more updated version of that last reference material, and we'll include that in the presentation as well, so that you have that. And again, this is recorded, and so we'll share it with our ACO partners, and anyone can watch it at leisure. So if you have other members of your team that you'd like to have see this, we will send that to you, and you can forward it along to them, and we'll embed it into something that can capture attendance as well. So, but if you join today, then your attendance has already been captured. So many thanks for that. All right, it looks like no other questions have been submitted. So again, thanks everyone for taking some time, and hope you enjoy the rest of your day, and look forward to continuing to work with you on this important matter. With that, thank you.
Yeah, hope to see you in person soon.
Yeah.
Aye, aye, aye.
Stay well.